to address, which was at the time the pandemic. And so the thing that we really have to view COVID in terms of the skills, though, that we developed and we exercised as a part of COVID. So things like behavior modification, personal protective equipment, contact tracing, and case investigation, which fortunately, and this is the beauty of public health, is that those skills are usually directly applicable to other situations and other conditions. And I think that's the case here. I think a lot of the same strategies are going to work for syphilis as well. So again, I wanted to start with historical information because we're traveling the state to really have conversations with you, and that's our goal with this. And DPHHS is happy to be co-hosting this event. And we really want to thank the Montana Public Health Institute and the Native American Development Corporation for being able to bring together such a large group of people, not just here, but in Polson on Monday and going to Poplar tomorrow and going to Lake Deer on Friday, bringing together a big group of people that we can talk to about syphilis and provide education. So thank you again for showing up, and thank everybody for joining us. We appreciate it. So like I said, I'm going to go ahead and just provide a brief syphilis overview, not for the purposes of comprehensive information, because Dr. Taylor will cover that later, but just for the purposes of this discussion. Go ahead next, please. And then I'm going to talk about syphilis trends just briefly on a national perspective, and then focus more in on Montana next. And then I'm going to review some syphilis outcomes for pregnant women in Montana from 2019 to 2023. And then we'll wrap up by talking about some state activities related to syphilis. Next. So just some key facts and baseline information. Syphilis is a systemic infection and it's caused by spirochete bacterium treponema pallidum. Next. It's transmitted by sexual activity, but can also be transmitted vertically, meaning from mother to infant during pregnancy. Next. Without treatment, syphilis symptoms and signs, if they were present in the first place, can disappear over time, and people may not be aware of their infection, but that can still cause long-term complications. Next. So if I'm giving some key facts, kind of a bottom line up front sort of approach, untreated syphilis can result in poor health outcomes for adults and infants. Next. It's a preventable and treatable disease, so that's the good news with syphilis. Next. We're experiencing an epidemic with substantial growth. Next. There are disparities in the populations that are affected, and we're going to talk more about that today as well. Next. Collaboration among a lot of different agencies is going to be required to help address this issue in our state, and that's going to involve federal, state, local, tribal, public health, medical providers, and the community as well. So it's going to be an all hands on deck sort of approach to address this issue in our state. Next. So I'm going to get into some of the data. Next. This is just a really nice kind of visual representation of what has been happening nationally. This is the data from the CDC that shows kind of a comparison of states that have been affected by a rate of syphilis that is more than 7.6 per 100,000. And you can see in 2012, it was really 2 states that had a rate that was that high. When you flash forward to 2021, you can see that 42 states, DC, and 1 US territory were impacted. So the bottom line with this, for the purposes of this discussion, is that Montana is not alone. This is something that's happening throughout the United States. Next. When we look at the companion graphic for rates of congenital syphilis, which is what is being shown here, it is a similar pattern where you have in 2012, there were 7 states that were impacted with higher rates of congenital syphilis. And then when you look at 2021, you can see that the United States is pretty much blanketed with high rates of congenital syphilis. And so, again, just to get a kind of national pulse on what's been happening with both syphilis and congenital syphilis. Next. The population that I really want to zoom in on for this discussion, and I hope that you walk away from this discussion with kind of an emphasis in this area, it's the fact that when women of reproductive age, so women that are classified as 15 to 44 years of age, 15 to 44 years of age. As the rates in that particular group of the population increase, the congenital syphilis rates track right along with that. And so this gives us our priority area for intervention because congenital syphilis is a sentinel health event, and this is our worst possible outcome from a syphilis infection. So it's kind of a tracks right along. Next. So I want to move into some of the Montana trends that we've been seeing. Next. So this is a snapshot of 2019 to 2022. And so in 2019, we had just over 100 cases of syphilis in the state. And the colors of the different lines don't matter as much, but they are a little bit more about the staging of syphilis. But if you look at the gray line, you can see that in 2019, we had just over 100. 2021, we had a little over 200. And then in 2022 is when we were over 600. So those counts have just continued to increase as we go forward. Next. This is a snapshot of what's been happening to date in 2023. So I can say that as of right now, we have about 340 something cases of syphilis in the state year to date. That's up about 40% as compared to where we were this time last year. And so the point being, we're continuing to move in an increasing direction. Some of the counties that are most impacted by syphilis in our state are Yellowstone, Roosevelt, Bighorn, Rosebud, Cascade, Missoula. Next slide. When we look at congenital syphilis cases, it's a similar appearing pattern. So in 2019, you can see the numbers here along the bottom. We had 2 cases of congenital syphilis. When we went to 2021, we had 1 case. And then we went up to 9, including 2 syphilitic stillbirths and 1 infant death in 2021. And then we went to 15 in 2022. So 15 cases of congenital syphilis, including 3 stillbirths and 1 infant death, or 3 stillbirths. So year to date, in 2023, we've had 9 cases of congenital syphilis, including 1 syphilitic stillbirth. And so it's a huge problem. And as I said before, congenital syphilis is the worst outcome of a syphilis infection. It is a sentinel public health event, meaning that something is happening in the system that is not working, and we need to find out what that is and how we can help address it. And that's why we're here today. Next. So what we did is we took a look at some of the data that we have for syphilis outcomes, thank you, in pregnant women in Montana from 2019 and up until June 5th of 2023. I didn't do this, I should say. Helen McCaffrey did this, and I give her credit for this work in terms of the data. So we looked at this and did a comparison. So we defined cases of interest as pregnant women who had a syphilis infection, who developed or had a baby, delivered a baby with congenital syphilis, or had a syphilitic stillbirth. So that was the definition for a case in this case. And there were 35 individuals, 80% of those resulted in live birth. And when we look at cases of congenital syphilis, we're looking in 2 data systems. So the MIDAS system for the information about mom, and then we're looking in a system called REDCap, which is how we report it to CDC. When we were looking at the comparison group, these are mothers who were diagnosed with syphilis during pregnancy, but developed babies that did not have congenital syphilis, and we'll refer to them as healthy babies in this presentation. So there were 45 individuals in this case, and this is all coming from our MIDAS system because there was not an outcome of congenital syphilis involved. And then women who hadn't delivered were excluded from this analysis. So when we look at some of the demographic information from women who had babies with congenital syphilis and those who had delivered healthy babies, we see that pregnant women, in terms of age, who delivered healthy infants tended to be younger than women who had babies diagnosed with congenital syphilis, which that was somewhat surprising to us kind of internally. But I think that what that flags for me is that we do want to rely on some elements of data when we're focusing interventions and prevention efforts and screening, because we can't necessarily make assumptions about who's going to be affected. In this case, it happened to be older women. In public health reporting, we generally classify race in this way. And what I want to call out from this is, and most notable, is that 83% of pregnant women who developed or to deliver babies with congenital syphilis identified as American Indian Alaska Native. And that's why we want to have this conversation and get to the root of what is happening here. Notably, pregnant women of infants with no congenital syphilis outcome but had syphilis during pregnancy, American Indian and Alaska Native group is overrepresented in this category as well. So this is a really informative graphic, I think. This is looking at pregnant women with syphilis by pregnancy outcome disease stage. And when you see the y-axis is just proportions, and then on the x-axis is stage. And there are 4 stages for syphilis, and Dr. Taylor is going to go into much greater detail about this later. The thing that I want you to notice and know for the purposes of looking at this graphic right now is that if you are categorized or staged as having syphilis in one of those first 3 categories, so early latent, primary or secondary syphilis, you require 1 injection of biosilin in order to be considered cured. When you get into the category of unknown duration or late latent syphilis, you require 3 injections, and those have to be administered a week apart, and there isn't a big grace period in terms of the 7 days spacing of that dose. So you can see that it becomes, you can imagine how challenging it becomes when you're telling a person that they need to have a painful injection on the day of their visit, and then they have to return 2 more times at a very tight interval. There are so many barriers to having that happen. And so Dr. Taylor, one of the things I appreciate about her presentation is that she's really going to emphasize this idea of ruling in and how you can do that at an earlier stage of syphilis, because it has really important implications down the road. But the thing that jumps out to me here when I look at this graphic is that in all categories, so women with syphilis, pregnant women without a syphilis or congenital syphilis outcome, and then women with a congenital syphilis outcome, all of those categories are most represented in that last column, which is where you're going to require the 3rd treatment, the 3 treatments. And so staging is really important with syphilis because that is the category we want to avoid if it's at all possible. If it's not possible to avoid that, then this is the diagnosis that we're going to have to put more resources in and follow through into making sure that effective and appropriate treatment is received by this person. So I think it serves a dual purpose of talking about the importance of staging and accurate staging, but then also the fact that this is the category that would be flagged as needing a follow-up, because there's a lot of congenital syphilis being reported in that group. So when we talk about prenatal care, and we look at pregnant women of infants who didn't have a congenital syphilis outcome, you see that a higher proportion had some prenatal care at the time of their diagnosis. It also appears that this group had earlier prenatal care or earlier time of diagnosis than the mothers who went on to deliver a child who had congenital syphilis. And so we know that prenatal care is important and access to prenatal care is important. We want to get people in as early as possible during pregnancy for screening and treatment for sure. And screening for syphilis is universally recommended at the first prenatal visit, which is generally in the first trimester of pregnancy. And so this isn't a priority area. The earlier you can get the screening done, the earlier the mother can be treated and the better the outcome for the mom and infant. So when we looked just at the group of women who had babies that are delivered babies with congenital syphilis, we see that 2/3 of them reported having their first prenatal visit in the 2nd or 3rd trimester. So that's late entry into prenatal care. And so this is another area that we can really focus on, making sure that there are not transportation barriers or that mothers have access to timely prenatal care as well. And that would be very important in this situation. So what are some of the things that we can glean from the case investigations that you all are doing that are entered into MIDAS? So just right off the bat, we had 35 outcomes with mothers with a baby with congenital syphilis. We could really only bring together information from 18 of those based on the investigation details. But these are some of the themes that we saw in the case investigation. So one is difficulty contacting the patient, meaning either they didn't have a phone or if they were unable, the person was trying to get in touch with them about treatment or follow-up was not able to establish contact with them, or maybe at a later date, be able to initiate contact with them. So communication and contacting patients is a challenge. We talked about late or inconsistent medical or prenatal visits, potentially contributing to some of those poorer outcomes because that was more consistently reported. Lack of appropriate treatment. I include this one because I think it's a really super important point of discussion. If I haven't said it before, I want to say it here. This was a situation where a woman presented, was diagnosed with syphilis, was treated, but didn't receive all 3 courses, let's say, for latent syphilis. So there was an inadequate treatment. The woman went on to deliver an infant who was classified and met the case criteria for having congenital syphilis. This woman still was not appropriately treated. And so she went on actually to deliver a second infant with congenital syphilis because there were missed opportunities in there in terms of screening and treatment. So I just think it's really important, and I say that I also want to emphasize that a woman may not be pregnant when you see her, and I just want to reinforce this idea of women of reproductive age, just more generally, because they may be pregnant next time you see them, and you just want to treat that disease early when it's easier to treat and it's, the person is right in front of you, because loss to follow up is another thing that's a really big deal in terms of challenges.
So other challenges in terms of identified from this case investigation would be substance use. And this can be a barrier to receipt and seeking appropriate care during pregnancy. And what I really want to say about this is I think we have to approach people in a really ultra compassionate way when they're presenting and they're pregnant and they haven't had medical care and they are dealing also with another chronic disease, which is substance use disorder. We need to really meet people where they are in terms of, they're presenting. We need to kind of set things aside sometimes and give them the care that they need. It's not working now. It's just
Okay, sorry.
okay. Well, there's a hand right here. Maybe I should try that. Okay, no, it's not working. So substance use, I just want to flag this because it is something that comes up, in 5 of the 18 cases that we were able to look at in greater detail. And I think that there's just a lot of potential, not only for stigma around STI, but stigma around substance use. And I really encourage us to take a compassionate approach here, because this is a big deal, and this is going to require better wraparound services even than just STI alone. We need to meet patients where they are. Another thing was one individual was in a correctional system, others had arrest warrants. And I want to make the point here that when there's the threat of law enforcement, or there is a concern, and this goes back to substance use too, when there is a concern that a mother is going to lose a baby because of substance use, that is a major barrier to getting them in for screening and treatment. And we really have to think critically about that, because it's something that came up in many different ways in the course of looking at this information, and also just through conversation and anecdotally speaking. So, you know, again, meeting people where they are and working with them is the only way that we're going to be able to offer and administer adequate care, particularly for pregnant women. And then incorrect treatment was noted in one case where an infant had a poor outcome. So we had a lot of limitations in terms of this data, some of which I've mentioned. You know, we only had information for 18 cases. And so it's a small group of data, but it does help us kind of hone in on some of the themes that we're seeing. And again, the best thing that I think the data does is it starts that conversation and really gets that going. So that's, we're thankful to the data for that, but we do have limited data. The fact that some of this information is housed in two systems can be challenging as well in terms of matching up information for baby and information for, it was this one, yeah, it just stopped. So in we are working on that in terms of making it so that all of the information is housed in one system, and that will just make it easier, not only for pairing that information, but also for summarizing and presenting and giving you all the information and the summary of the hard work that you've all done as well. Again, lack of just some of that qualitative data for pregnant women. Thank you.
We are hiring a nurse consultant who can help extract some of the data from MIDAS and get more information to be able to summarize this pretty efficiently as well. So, and then just incomplete data. We do find that there is incomplete information on demographics. Pregnancy status is useful. Treatment information, partner information is all very important, and but we do have missing data fields, and so we recognize that our data set is limited. So one more thing I wanted to touch on is the bicillin shortage. And so, you know, we learned about this in April of this year. And the date of expected resolution has been somewhat of a moving target, but we did hear earlier this week that that is now expected in Q3 of 2024. So that's late summer of next year. And so I put a couple of resources on here that talk about prioritization of supply. This is the treatment for pregnant women, and so we have to make sure that this supply is available for those pregnant women who are presenting for care, that we're able to at least administer in that population. It's incredibly important. We have heard a little bit from sites about lower supplies or just kind of more curiosity about, you know, how Pfizer is doing their allocation. Pfizer is a sole supplier of bicillin in the US. That's it. They're the only one, and they're experiencing a demand that's outstripping their supply essentially. So we've heard about sites kind of asking questions, but if you are having any stress related to your bicillin supply, please let us know, because we do reach out to CDC, to FDA, to Pfizer. We can't do a lot, to be honest. I think that's the unfortunate part of this, that it is truly a supply issue. And Dr. Taylor will talk about prior bicillin supply issues and kind of timelines for resolution and that sort of thing. But as of right now, there is a shortage and is not expected to be resolved until next year. But please let us know if you are experiencing that issue. So with that, I'm going to turn it over to Christy Applestad, who's going to come up and talk about some of the DPHHS's activities related to syphilis. Thank you so much. I look forward to our conversations today.
Thanks, everyone. My name is Christy Applestad. I'm the section supervisor for the STD, HIV, and viral hepatitis section at DPHHS. And I'm so excited to see so many bright, shining faces out there. When we first dreamed up this idea, I would have dreamt that it might be this big, that I probably didn't even hope. So thank you all for coming and talking about this important topic. Before I start, I just want to talk a little bit about the life cycle of a case, essentially, of a communicable disease, particularly syphilis. So as most of you know, the person will be diagnosed by a local provider, in some cases a payment planning or an STD clinic or at a health department. And that test then is transmitted into, I guess I'm slightly taller than Peggy. And so that case, then the lab report is transmitted into our database for communicable disease called MIDAS. And at that point, then both the state health department and the local health department can see that information. And then generally the local health department or tribal health, IHS, goes out and investigates that case and shares that information back into the system, and then it comes to the state health department where we review it, analyze it for trends, just as you saw Maggie present so well. And then we transmit that information to the CDC. And I think that it's really important to note that health is local. We could never come up with the energy in Helena in order to be able to address this issue across the state. It really comes from all of you. And we appreciate the work that you all are doing every day in order to make that happen. Some of the things that we do at the state health department, like I said, we analyze and look at the data for trends. We look at it across jurisdictions, and then we can see where there are maybe pockets of activity higher than we would expect. We share that information with the CDC, and they look at it the same way, but across states. And so that's really helpful, as you've seen from some of the data that's presented. And it's also helpful because, communicable diseases, syphilis doesn't stay within county lines or tribal lines. It's spread across the state. And so that also is a helpful aspect. The activities that we do really can be lumped into 4 categories. We work on training and outreach, and we've had several opportunities over the last year to do a lot of training and outreach. Some of the training that we've done specific to public health is through a contract that we have with the University of Montana. We're offering disease intervention specialist trainings called Project Echo. And those trainings are held every 2 weeks. And they have a facilitator that does them. There's a didactic portion where there's a presentation. And some of the topics that we've done recently are congenital syphilis, lab testing and interpreting lab results, and staging of syphilis. And those are available to anyone. You can all take them if you aren't already doing so. We'll make sure that you have the information to sign up for them if you haven't. And then the other part of the GIS echo is really important. So there's a didactic portion, the presentation part, and a question and answer. And then the last half of the echo is someone presenting a case that they have with questions that they need to resolve. And then the whole group can participate and ask questions of the person and then give them recommendations. And this is really important because it creates a learning community where people are sharing information with each other and networking, and we're all learning from each other. So that's been a wonderful addition to what we're offering. Another opportunity that we've had through our contract with the University of Montana is to create some disease intervention specialist modules. And those are available to everyone as well. And some of the topics include chlamydia and gonorrhea and syphilis and partner services as well. Those are really helpful information. They include curriculum from the National STD curriculum as well. And then we've had some opportunities to reach out through local public health to providers across the state. One of those opportunities was the call to action that Dr. Kushner wrote in December, and we disseminated that to local and tribal health departments across the state with the call to action to talk to their providers in their communities, because again, health is local. You all have those relationships with your local providers and can talk about what's happening in your area and then what they can see across the state as well. And that provided background information about the rise in syphilis, along with screening and treatment recommendations and control measures. And then another opportunity that we have is through the University of Washington Clinical Training Center. They have both recorded sessions that I'll provide a link to in a later slide. But they also provide a clinical training, and that's usually offered about once a quarter, and we subsidize people attending the virtual as well. And then lastly, this event came together. We worked with our maternal child health partners and the Family and Community Health Bureau at DPHHS to fund the Syphilis Symposium and the community engagement activities that we're doing across the state this week in some of our most affected communities. And this is really just so that we intend to learn as much from these as we hope that you learn. We want to understand where knowledge and service gaps exist and work collaboratively across agencies to address those. The next category is technical assistance. The DPHHS staff provide technical assistance to local and tribal health in entering cases in MIDAS and in different aspects of case investigation. We also, through that contract with the University of Montana, have one-on-one coaching from an experienced public health nurse, CIS, who's able to answer questions, help troubleshoot cases, and help give next steps for people. And then we have access to clinical consultation for complex cases in coordination with the University of Washington and the Clinical Consultation Network, which is funded by the CDC. Next, we work on surveillance and assessment. So all of those cases that you send to us, we review those case investigations and then communicate those to the CDC. We're currently doing a project with that information. It's a quality improvement project to improve rates of appropriate treatment in pregnant people and people who could become pregnant. So we sort for those cases that don't have a pregnancy status, or their pregnancy status is unknown, or they're pregnant. And we follow up with the local or tribal public health to get that information, and then also are assessing whether appropriate treatment has been completed, and if not, providing those MIDAS numbers to those local jurisdictions so that they can follow up on those cases. And then last, we're in the process of creating a congenital syphilis case review board. So as maybe noted, there's limitations in the data. Partly because we only collect the baseline information at this point. So through that congenital syphilis case review board, we'll be doing case abstractions, utilizing medical records of people who had that health outcome of congenital syphilis, and then also any social records that we can get, and a more thorough maternal interview in order to get more information. And this will help drive prevention efforts across the state once we understand more what some of the issues are. And then lastly, we collaborate with CDC, requesting technical assistance and other assistance in order to address the outbreak. I just wanted to quickly go through one case discussion. This is not built on any one certain case. This is a conglomeration of a number of different things, and I think it'll sound familiar to many of you who have worked with people who have had syphilis. Abby presented to the emergency department in October 22 with UTI symptoms. She was positive for UTI and a pregnancy test. The ultrasound confirmed dates at 14 weeks, and she was referred to prenatal care. Her prenatal labs included a positive TPPA and an RPR of 1 to 128. Abby presented to prenatal care 2 months later in December and had a rash and was treated appropriately with isolin 2.4 million units IM. On the day of treatment, they did a titer so that they could make sure that it came down fourfold from that point, and it was 1 to 64. She stated she'd broken up with her boyfriend and she declined to name any partners at that time. Abby doesn't present for prenatal care again. The public health nurse is trying to reach her, trying to find her, and she's lost to follow-up. The next time we see Abby, she presents to the emergency department in labor, and her RPR is 1 to 128. And she's with the father of the baby. Abby delivers an infant with an RPR of 1 to 32, and that infant's transferred to the NICU and treated for congenital syphilis. Abby's intersected with many of the healthcare providers in the public health system on several occasions. Many of you probably have experienced patients similar to Abby, and in some cases they can be difficult to find, not following up on recommended healthcare, and potentially not naming partners. becoming reinfected. But have you thought about this from Abby's perspective? Maybe Abby was living with her 3-year-old and her boyfriend. When they broke up, she had to sleep on other people's couches until they got back together. She didn't want to share his name as a partner because she was afraid of his response. When it was time for her prenatal appointment, she didn't have a ride, and she was scared because she thought she might get billed for the appointment because it was a private provider. She often thought about her baby and worried day to day about how she was going to feed her 3-year-old. Maybe she got back together with her boyfriend, and she was relieved about not having to think about where they were going to stay and didn't want to upset him by telling him about the syphilis. Maybe she didn't realize she could get reinfected, or maybe she did, and it was a trade-off for having a safe place to live and food to eat. She may have also been dealing with substance use and worried that someone would take her baby away if she went in for care. Today we're going to present a lot of data, and we've presented a lot of data to you, and I just want you to remember that behind every single one of those numbers is somebody like Abby, a person in our community who is experiencing more than just syphilis. They're experiencing a lot of different factors in their life that are affecting their ability to get care. And I know it can be frustrating, and I know it can be really challenging to manage these kinds of pieces. We totally get it. But we're just seeing it increase, and and I just want you to remember that behind every one of those is a person. So with that, when you see us around today, I know that many of you are the holders of more information than goes into MIDAS. You've seen these patients, you've heard their stories, you've had the challenges of trying to follow up with them. Catch us. Tell us your stories. Tell us what you're seeing or what trends you're seeing in your community. Those are the things that we want to learn about. And then as we kind of gather that information, we can also use that for further prevention efforts. So we just really appreciate everything that you all do to do that, and would appreciate hearing those stories. This is just a slide on resources, and you'll get the slides after the presentations. These are some of the resources that I was talking about earlier. The first is the STI treatment guidelines. These treatment guidelines have so much more than just treatment. For those of you who've perused it before, it's a wealth of information about how to follow up on cases, what you should be looking for, test results that you would expect to see. The second one is for the clinical consults that I talked about from the University of Washington. They're excellent resource for people who have complex cases. They do a provider-to-provider consultation, and they're usually pretty quick. They guarantee in 5 days, but in our experience, it's usually a day, maybe 2 days that you would get information back. And then the University of Washington STD Prevention Training Center presentations, they have course recordings and specifically syphilis resources and trainings as well, and they're all recorded with excellent presentations. And the last is a link to the University of Montana Disease Intervention Specialist Training modules, and you can access it through that link. And then last, this is just our contact information. So if you don't manage to catch us today, or you don't have a story to share today that you have for next week, next month, next year, please feel free to reach out to us and talk to us about the things that you're seeing in your community and how we can help. And that's it from us. So I'll turn it over to Cora to introduce Dr. Taylor.
Maggie and Christy. So we are going to share all these materials so that you can refer back to it. But it's Christy ran through a huge number of resources that you have that DPHHS has made available. Bi-weekly disease intervention specialist trainings, disease intervention modules, the trainings with the University of Washington, one-on-one coaching and clinical consultation, and the list goes on. But one thing we want to make sure to reinforce today, and this is not just for clinical, right, Christy? This is not just for clinical providers, it's also for community partners. We want you to feel comfortable reaching out to DPHHS. They can't do their work without you, and they also need to learn from you. So they're making as much available as they can. I know there's funding for testing and support with that as well. So thank you for reviewing that, and please do remember that they're there to help serve and make your work easier and more effective. So now, very honored to have Dr. Taylor with us here in Montana, and I'm just going to introduce her and move on to the next portion of the clinical training. Dr. Melanie Taylor is an infectious disease internal medicine physician. She's a captain in the U.S. Public Health Service and a medical epidemiologist for the U.S. Centers for Disease Control and Prevention in the Division of HIV Prevention. Dr. Taylor is a practicing HIV physician at the Phoenix Indian Medical Center and is a clinical associate professor with the University of Arizona College of Medicine since 2012. During 2016 to 2020, she was assigned to the World Health Organization in Geneva, Switzerland to lead global efforts to eliminate mother-to-child transmission of syphilis and HIV. She's a member of the WHO Global Validation Advisory Committee for the elimination of mother-to-child transmission of HIV, hepatitis B, and syphilis, all challenges we have here in the state. She's currently assigned by CDC to the Arizona Department of Health Services and the Maricopa County Health Department, where she assists with STD, HIV, and congenital syphilis prevention treatment at the public STD clinic. So thank you very much, Dr. Taylor, for joining us, and looking forward to your presentation.
It's a pleasure and an honor to be with you today, and thank you all. I know many of you are fellow travelers, and I appreciate your efforts to get here today. I have some sobering information to share with you, and some of that's going to include clinical presentation of syphilis. These will be clinical slides, graphic presentations of what some of the symptoms are. But what I want you to remember are a couple of things, and I think that one of the important things to remember is about STIs in general is that most people who have them don't know it. And syphilis is one of these, particularly because of the pathophysiology of this bacteria, not a virus, bacteria, and the way that it invades the body and the different organ systems. It is called the great imitator, the great masquerader, and so it is an interesting infectious disease for that reason, but what that means is that it's oftentimes missed by the patient, by the provider, by the public health system. And what that results in is ongoing transmission, both sexually and vertically. Vertically meaning from mother to infant, during pregnancy or at the time of childbearing, and that is really the worst outcome of the outbreaks that are occurring across the United States and in the state of Montana. So it's really helpful to be preceded by Dr. Kuchmanek and also by Christy to give us an overview of both the morbidity, mortality of syphilis in Montana, as well as the services that are in place and are available for you to outreach to from the state. So I'm going to start with an overview of the clinical manifestations as well as the surveillance for syphilis in both adults and infants. But we're going to talk first about the fact that we need to approach this from a patient perspective and from a syndemic perspective. So I'll ask to advance to the first slide. And what I mean by syndemic is that there are sort of conditions, clinical and non-clinical, which occur at the same time due to overlapping background risk, overlapping transmission rates, for example, STIs, which include hepatitis B and C, sexually transmitted infections, HIV, human papillomavirus, trichomoniasis. All the STDs are, of course, transmitted sexually, but sometimes there's a syndemic that includes a background risk factors. That includes social determinants of health, substance abuse, other background elements that increase someone's risk for being at risk of these conditions, whether they be infectious or not, that increase their risk. And so in order for us to address syphilis, we need to address the background risk of other conditions among individual patients, both pregnant and non-pregnant. So the issue is, as we address these syndemics, we want to consider syphilis as a top priority because that is where the epidemic currently lies. But we also want to recognize that there are specific at-risk populations or vulnerable populations that we need to make sure that our services reach. And right now, those include LGBT communities, our pregnant women, top priority, persons in corrections, persons using substances, next slide, and also persons that may be at a disadvantage for approaching, accessing, and accepting or choosing to attend medical care services, where our ability to access and offer them medical care resides. And what that means also is that when they don't have access to medical care, we need to bring it to them. And when I talk today about syphilis, I will talk to you specifically about how to bring the STD testing, how to bring the STD treatment, syphilis treatment to them when they cannot make it to your facility. It's very clear that we have the resources to go out into the community, but oftentimes women, vulnerable populations don't have transportation, they don't have childcare, they're in a situation where they don't feel safe to leave their home to approach the healthcare system. And so at this point, and in this outbreak, we need to go to them. We need to offer the services where they are. We need to make sure that we understand what those vulnerabilities are. So these things I've already talked about, and then the background of that is a very high cost. It costs, at least in Arizona, about $100,000 to treat an infant who has congenital syphilis with IV penicillin over the course of 10 days in the NICU. So it's not just about you have to factor in that this is a high cost as well. Next slide. All right, so the rising rates of STIs is why I'm here, specifically for syphilis. But in the background, what we know is that there are rising rates of drug use, and that includes both opiates as well. Okay, let me try this. Thank you so much. So what I mean is the background rates of increasing substance use, whether that be methamphetamine, as it is in the area where I am in Arizona. Now we're adding fentanyl on top of that. In the background of that are prescription opiate use, which is probably one of the founders of this problem across the United States. We don't want to forget, again, that sexual transmission of hepatitis C is occurring. In fact, 4 in 10 of the new hepatitis C cases are sexually transmitted. So we need to recognize that it's not necessarily IV drug use that's fueling HIV and hepatitis C, but rather sexual transmission in addition to our other STIs. So today it's about syphilis, but please remember that we have a syndemic. We need to have a syndemic approach. We need to make sure that we access and offer services to our most vulnerable populations. And in this particular situation, quite different.
For anyone who doesn't understand that.
Yes, so it's endemic again, as I mentioned before, it's when you have a group of conditions. Some of those may be infectious diseases, but for which there is a background of similar transmission routes, similar vulnerabilities or access to care or background social context for which that puts that patient at risk. And opioid or drug use is another part of this syndemic. So again, syndemics are those where you have overlapping risk factors, transmission routes, and social context for acquisition of these conditions or experience of these conditions. So that means that we need to have this as a holistic approach, patient-centered approach, and we need to take the care to them where they are. So one of the things I want to start out first with is that the Indian Health Service, for which I'm a medical provider, although I work for CDC, I am also a medical provider within the Indian Health Service. The Chief Medical Officer has offered not strong recommendations, but expectations for the Indian Health Service to implement and approach the syndemic and specifically the syphilis outbreaks of American Indian Alaska Natives with her specific recommendations. If you're working for a 638 facility, I would encourage you to adopt your situation to this as well, because this is now best practice. So here we go. I'll mention this again as a summary. That the first off is an annual syphilis screen for everyone between the ages of 13 to 64. Now, this is the first time in the United States that any one agency, and that includes CDC, has ever come forward with a syphilis screening recommendation. You know we have one for HIV, you know that we have one for certain populations for hepatitis C, but this is the first, and it's novel, and it's appropriate at this point that everyone who is seeking care at an Indian Health Service unit, and I would say 638 as well, urban Indian health centers as well, get tested for syphilis. Adoption of a bundle. As we talked about the syndemic approach, talked about the syndemic, we do recognize that when you have access to a patient who might be at risk for syphilis, you don't want to test them for just syphilis. And in the history of STIs, we have done such a disservice by testing people only for HIV. Let's not do that anymore. Let's recognize the patient. their sexual risk, other risks that they may have, and offer them a complete set of services and testing, screening opportunities for all of the infections for which they may be at risk. And that means that you need to understand the risk. That means you need to offer a syndemic bundle, and this is what that looks like. Please remember that pregnancy is sexually transmitted. I think we're all here for that reason. But you would possibly be surprised at how often that's forgotten. And what I mean is that patients will be tested for HIV and they'll be tested for other STDs, diagnosed with an STD, but they will never be tested for pregnancy. And all of these infections, all of them, are transmitted vertically. That means that infant is at risk for those STIs. So please don't forget that that is a part of your syndemic bundle, and it's not an infectious disease, of course, although I would consider that if you did consider it an ID, then it does last about 18 years. If you're lucky, maybe a little bit longer than that, or at least the financial cost of it. Okay, so we want to make sure that we screen outside the community as well. As I mentioned before, a lot of our populations in Arizona, and I can speak to that, are rural. The COVID-19 has put a lot of people at social and financial disadvantage, and that means that they sometimes can't afford gas, they can't afford the minute cards that will fuel their telephones, get text, and they absolutely can't afford necessarily to answer a call on their cell phones. And so we need to think of innovative approaches. We need to come to them where they are. And we need to expand the scope of work for some of our staff designations so that they can go out into the community and offer services, that being testing and treatment for patients who are at risk or infected with STIs. And then one of the most important things from the Indian Health Service for our populations of American Indian Alaska Natives at risk for or infected with syphilis is that we need to take that penicillin dose, put it in a cooler, put it in the truck, and go out to the patient and give them that injection at home or in another place where they feel safe, such that they don't have to make that trip all the way 40 miles into the Chinle or Tuba City, Navajo area service unit. So that's my spot. Yours is going to be different, but you have to remember that, again, it's our responsibility to get patients treated. They can't always accept that responsibility, so we need to take on that for them. All right, and that's the recommendations from the Chief Medical Officer of the Indian Health Service. So we'll go through that again. I'm not going to touch on this benzodiazepine penicillin shortage. It's one of the ironies that I have in my career as being the person who investigated this. The global shortages in WHO, where we had over 40 countries that ran out of benzodiazepine penicillin between the years of 2015 to 2017. This is a travesty in the United States, and I would say it's not a political platform, but we have only one provider, only one manufacturer of benzodiazepine penicillin in the United States, and that is Pfizer. Yeah, they hold that drug a bit hostage, and it's not completely their fault. It's the only FDA approved product in the United States, while the rest of the world gets the product for about $1 a dose. It's sold from Pfizer for a cost between $200 and $350, sometimes $400 for one single dose. The HRSA 340B price is 12 cents a dose. That's public health pricing. And so you can see the huge discrepancy, but what that means is, and this is the situation in Phoenix, is that in order for a pregnant woman who, as far as she knows, she has one sexual partner, in order for her to get treated for syphilis, she's got to march herself down to the STD clinic, right? So that means that it takes her effort to get treated. When her private provider diagnoses her with syphilis, they then say, well, you've got to go to the public clinic because I can't afford to stock benzodiazepine penicillin in my OB practice. So this is one of the disparities that we see, and it's unfortunately perpetuated even at the highest levels with access to the first antibiotic in the world, benzodiazepine penicillin. There's so many ironies with syphilis. So here I want to remind you of some of the upcoming trainings. It was really helpful to hear from Christy, the trainings that are available for disease intervention, for clinical training for STIs and syphilis. Please consider also that we've got 2 trainings coming up. One is for substance abuse and another symposium virtually on syphilis. These, you can scan that QR code or go to the Northwest Portland Area Indian Health Board ECHO to to access those and register. So now let's go over some of the epidemiologic and clinical aspects of syphilis. I want to make sure that we have some time for questions at the end, so please jot those down now, and we'll have a question and answer session. We hope that we can hear some of the stories, some of your experience as well. So this is the first thing, and I want to say, first off, yes, I work in Arizona, and we now have the top ranking in the United States for congenital syphilis cases, rates, congenital syphilis case rates, and that includes the denominator for those of you who do statistics. That means that we don't have a very large population in Arizona. You guys don't either. And when you have a few cases of congenital syphilis, that bumps your rate up really fast in comparison to places like California. But what I'm trying to draw attention to here is take a look at the states that are now above the US average. And keeping in mind that these are some of the areas where we have tribal populations, tribal lands, and urban Indian populations. And these are now in the higher levels of congenital syphilis. So Arizona, New Mexico, we have tribes that cross the border into both states, and they are contributing congenital syphilis cases among American Indians. We also have Oklahoma now, South Dakota, as well as Montana, where you are and we are now, that has reached and surpassed the US national average. And so this is an urgent public health matter. As we talked about before, congenital syphilis is a very serious condition in newborns. But what folks oftentimes don't realize is it's the second leading cause of stillbirth in the world. And the first leading cause is malaria, which we don't have native cases. All of the malaria cases that we have are reported. So this is our national concern related to the stillbirth prevention. And so we want to draw attention to it. We want to increase awareness, and we want you to prioritize this for your services, both clinical, public health, substance use, and otherwise, to make sure that we have access to screening and treatment for your patients. All right, let's keep going. It's a bacteria. It's a bacteria. It's a bacteria. It's not a virus. That means we have a curable antibiotic. What is that antibiotic? Penicillin. Right, the first one developed in 1950, commercially produced and distributed in the 1960s. And this organism, this bacteria, is not resistant to it. It is the best treatment. There are alternatives, but the alternatives are not as good because you have to take a pill multiple times a day over multiple days. And we all know if you've done that, it's really hard to even take a vitamin every day. It's just difficult. It's not easy to do. And a lot of our patients who also have other challenging conditions, it makes it even harder for them to take a medication every day. For that duration can be up to 28 days for patients who have late latent infection. There's 4 stages, as Dr. Kuchamanik already mentioned. I'm going to go through some of the clinical aspects of that, which are going to be graphic, but it's important for you to know so that you can just recognize that patients may have symptoms. Most of the time they don't know they have symptoms, or they actually avoid acknowledging that they have symptoms in hopes that they'll go away. And unfortunately with penicillin, they do. Unfortunately with syphilis, they do. And that is misleading both to patients and their providers. So here's a county-wide look. And again, because I'm from Arizona, I find this map very discouraging for our state in the south here, but also knowing that you have already seen the counties that are even more up to date that are heavily affected by syphilis in Montana. Our northeastern counties in Arizona and our Navajo, Apache, Coconino County are heavily affected, reflecting the increase in cases among our American Indian populations. We've already seen this again. This is adult syphilis. We have a blue blanket fold across the United States. And now in 2022, we already know that all states are affected. This data from CDC is delayed. It doesn't matter how much we ask for more rapid data. It just takes them this long. The reason is we give states 6 months to clean and close their data after the year end, and then it takes us about 9 months to generate a new report. So our next report for 2022 will come out in March of 2024. For primary and secondary syphilis, these adult stages of syphilis, which have very graphic symptoms, what we saw in 2021 is that for the first time, American and Alaska Natives have now adopted the first or the highest rate of these stages of syphilis in the US. So we need to address that. We need to address it urgently because these populations of American and Alaska Natives now have more of an equal male to female ratio. And what does that mean? Well, that means heterosexual transmission versus previously we saw higher rates among men who have sex with men. And when you have heterosexual transmission, that means the risk of pregnancy as sexually transmitted condition is higher as well. Thus, vertical transmission is going to happen. When you talk about the progress between one stage to the next, you have this sort of linear progression of stages. And what this means is that when patients present, or when they first are exposed to the Treponema pallidum bacterium, they may become infected. There's an incubating stage at which our tests may be negative. And for that first thing, I'm going to say it now and I'm going to say it again. If you have a sexual partner who says that who has been named as a sexual partner by one of your cases, when that sexual partner comes to you, you don't need to test. CDC recommends that you presumptively treat them, and then you can test later if you need to. But if the test comes back negative, does that mean that they don't have syphilis? No, because there's an incubation period where we know from other infectious diseases that the test can be negative, but they have an incubating infection. When you're not diagnosed at that stage, which maybe you won't be, you progress to primary syphilis, which is characterized by a chancre. And the chancre can be one, it can be multiple, usually it's one, and it's going to be at the site where you were initially exposed. There's lots of things to remember about a chancre, but the first thing to remember is that it doesn't have any pain associated. It's pretty big and ugly, but if it occurs in the vaginal canal, the rectal canal, inside the mouth, inside areas between the folds of the pubic area, the skin area, patients don't know they have it. They may see it, they may know they have it, but they don't want to acknowledge it, they don't come in. And if they don't get tested and treated for this particular stage, that goes away. They progress to the secondary stage, which is characterized by lots of skin manifestations and other things that can mimic other infectious diseases and oftentimes are missed. If they don't get tested and treated at that stage, those symptoms go away. But meanwhile, the bacteria is transmitting itself to all organ systems, including the brain, the nervous system, the fluid that encapsulates the brain, spinal cord, the bone, the heart, the liver, the spleen, all organ systems. It's a very pervasive and invasive bacteria. And then if they don't get diagnosed, treated at that stage where those symptoms occur, they enter into latent stages where there are no symptoms, but yet they are still having progression. What's important to remember is that this bacteria goes to the central nervous system right away. So you can have neurosyphilis, you can have ocular syphilis, you can have otic syphilis, lose your vision, lose your hearing early on in syphilis or later in syphilis. At any stage, you can develop the neurologic manifestations of untreated syphilis. This is primary syphilis, characterized by a painless lesion because the bacteria invades the peripheral nerves and causes you not to have sensation. This can occur in the mouth, in the vaginal area, in the penis, in the rectal area. And if you can't see it, then you may not present for care. But if a patient with syphilis comes to you, they've been screened and they have positive tests, it is in our best interest as clinicians and in our best interest as public health practitioners, which I would like to ordain you all now as public health practitioners. I think we lost the mic. The battery's dead. Okay, I can talk loud. You want to endeavor to find a lesion, endeavor to find a rash, endeavor to look at the mouth, look at the anal canal, look at the penile area, in the vaginal area if you need to do a brief speculum exam, look for lesions. And the why is that? Well, Dr. Cook-Shamanik discussed this already, and the reason is these patients need a single injection of benzoyl penicillin. One injection equals a cure. So if you don't have these symptoms and the patient cannot tell you when they were exposed to syphilis, they are committed, and we are committed as providers, we are committed as the public health community to give them 3 injections spaced by 1 week apart. And that's a 3-week interval for which that first painful injection, which is like injecting olive oil through a needle into your hip, they are not incentivized to come back, right? So we want to endeavor to find a reason to treat them with 1 single dose. And that is important for us to remember. These are some of the symptoms of secondary syphilis. Secondary syphilis, also highly infectious. These 2 stages are the most infectious to the unborn infant. Vertical transmission is nearly 100%. And that means that when moms are infected with syphilis during pregnancy, the risk of congenital syphilis is very high. And that risk, I think, is why we need to see pregnant women early in prenatal care. We need to get them tested and treated as fast as possible. So that we can prevent and treat the infant. The injections of benzathine penicillin cross the placenta, and the adult dose is a whopping dose for that baby, and it clears them up of this bacterial infection. And so we want to make sure that we, again, bring pregnant women as fast as possible. We look for lesions. We look for lesions among all adult patients that have been diagnosed with syphilis. And we want to remember that some of these symptoms can be mistaken by dermatologists, primary care physicians, pediatricians, anyone who is not familiar with syphilis, and they might be mistaken for something else. That's by the patient, that's by the provider. So it's important that we increase the awareness of syphilis. We increase the awareness of syphilis at the community level, at the provider level, at the public health level, so that these symptoms can be recognized and you can treat your patient with just one dose, which equals the cure. We're going to talk about the latent stages, and those latent stages are those where you may need 3 doses. So let's keep going, but please remember that the great imitator, the great masquerader can cause hair loss in the scalp, in the beard, in the eyebrows can just completely fall out, loss of pubic hair. You can have lesions that look like genital warts, mistaken for genital warts in the genital area. You can have cardiac symptoms. You can have neuro symptoms, eyes, ears, as we've already discussed, meningitis, and stroke. These things are not often attributed to syphilis and definitely not attributed to sexual activity most of the time, and so they are misdiagnosed, and then patients progress to this latent stages. The latent stages. Now, here's our last opportunity for a single dose of benzathine penicillin. If we can rule in the fact that your patient and my patient or anyone's patient was exposed and infected with syphilis less than a year ago, then we can rule in early latent syphilis, which requires 1 dose of benzathine penicillin. So one of the sneaky advantages of doing universal screening for syphilis among your patients is that you are now going to have a negative test in your medical record. When your patient comes back positive, you can link those 2 intervals, and if that negative test was less than a year from your new positive test, that's early latent disease. If you can get a good history from your patient, and you can find out that they've only had sex with one person, young adolescents, then you know that that's early latent. When you can ask the patient, they said, you know what, I had a rash on the palms and soles of my feet. I didn't know what that was, but it went away. That was about 6 months ago, boom, early latent. Also, when we have very good disease intervention specialists, communicable disease investigators, public health nurses that take the time to ask patients, you know, did you notice a lesion on your partner? Did they mention, or have you been connected to anyone who you think may have syphilis? The public health nurse can get in the sexual partner confidentially, and if you can rule in a diagnosis of the sexual partner and link your patient back to that sexual partner within a 1-year period, again, this interview period can give you an early latent diagnosis, and that's only 1 injection of benzathine penicillin. So use these techniques, try it at all costs to rule in early latent primary syphilis with a chancre, secondary syphilis with a rash, or again, early latent less than a year, so you can give 1 dose of benzathine penicillin. If you are stuck and you cannot figure this out, well, good luck to you and all of us, because it's very hard to get 3 injections of benzathine penicillin into patients. It's painful. They don't want to come back for this first one. They may come back for the second. They don't want to come back for the second and third shots. They may come back, but the interval is too long because it's a narrow window. If it's a pregnant patient, you've got to get those second and third injections in between 7 and 9 days, or you have to restart. And we're running out of penicillin. We don't have time for that. We don't have penicillin for that. And we want to make sure that we have the appropriate follow-up, and that may mean that you need to put the penicillin in a cooler, get a penicillin in the cooler in the truck, and go out to treat the patient to make sure you get these doses in the correct time. The same type of history applies here. You can try and roll in if you want to when that patient was exposed, but if you can't do it, you're still stuck with those three injections. At any time, at any stage, of syphilis, you can experience neurosyphilis, ocular syphilis, otic or ear syphilis. And this requires a different treatment. Instead of doing the injections in the hips of the patients, they need to be hospitalized and get IV continuous infusion of aqueous penicillin for at least 10 to 14 days. So this is a much more serious condition. We're seeing this more. You may be seeing it, but you may be also missing it. We've had a couple of really curious cases happen in northern Arizona where it was the only symptom, and the patient went to the ophthalmologist, and it was just the luck that there was a medical intern rotating with the ophthalmologist that day, and the intern told the ophthalmologist, she's like, you know, there's a syphilis outbreak, maybe we should test this patient for syphilis. Sure enough, it was optic syphilis, would have been missed, because a lot of our providers in dermatology, ophthalmology, again, primary care, even infectious disease, you would be surprised sometimes, it just doesn't come to mind. But it should now, and it should now in Montana, because I'm telling you from the experience of Arizona that we don't want to miss this for the sake of patients who have serious manifestations and for the sake of pregnant women and those women who are in childbearing ages. Tertiary syphilis, long ago, Al Capone, Hitler, but we don't see this much these days just because there are a lot of antibiotics out there that partially treat syphilis, but it does go to all organ systems. All right, this is the part where I start to lose people, I start to lose myself, because it does get a little bit tedious to think about how to diagnose syphilis, but the bottom line, you need a blood. You need a serum, or if you have rapid testing available, you need a finger stick. And you need to screen confirm, screen confirm, screen confirm. You screen confirm for HIV, not so much different, and you actually don't get the choice of what test to order because your facility determines what syphilis algorithm is performed. And that's based on cost, sometimes it's based on turnaround time, sometimes it's based on the send out to larger laboratory corporations. But the bottom line is we like to screen, first test positive, confirm. One of the tests is very important. The RPR is part of both algorithms. And this is where we get a titer. And that titer is what we use to gauge the treatment response. We want to see the titer go down after you get penicillin, but also reinfection. Patients who are re-exposed and reinfected because their sexual partners were not treated. I'm going to say it now and I will say it again. It's possible you're going to hear it a third time. The best way to find syphilis in the community is not to screen everybody. That's the CMO recommendation, yes, because we're in dire straits now. We need to make sure that we understand who is infected. The best way to find undiagnosed syphilis is to find the partners, the contacts. This is case investigation and contact tracing at its best, at its most historical, successful, as the most historical and successful intervention that we have. We do it for Ebola, we do it for HIV, we do it for TB, we did it for COVID-19. It is a tried and true public health intervention, and it is the most effective. But if we don't do it, the ongoing transmission will get worse, and we know that because we had to redeploy or send our case investigators over to COVID for the last several years, and now we're paying the price across the whole of the United States. Those very trained and experienced CIS were reassigned, and now we're facing that as a fallout. So this, please don't get too worried about this. It is complex, it can be complex, but just remember, screen and confirm. If you get two positives, then that's a case. Unless your patient has been diagnosed and treated in the past, you can have some residual seroscars, serofast. It means that the treponemal test is going to be positive for your whole life, and the non-treponemal test will have low-level positivity for several years until it reverts to negative. And in some patients it doesn't. So if you get stuck, please reach out. Reach out to the state. You'll have my email. I've done consults on Montana cases in the past. Please reach out to us and we can give you a quick answer. Also, the University of San Francisco has now a warm line for STIs. They're really good at syphilis. All right. The treatment of syphilis is penicillin, penicillin, penicillin until we run out. And then it's going to be doxycycline for everybody but pregnant women. It's one dose for primary, secondary, and early latent. And if we're unfortunate to have to diagnose someone as late or unknown duration, well, that's 3 injections of benzathine penicillin or 3 treatments of benzathine penicillin spaced 1 week apart. Now, how does Pfizer package the medication? They package the medication in 1.2 million unit doses. And what that means is that for every treatment, you need 2.4 million units. So that means not only are you going to have to get an injection in one hip, that's going to be 1.2. Then in order to get to 2.4, you got to give it in the other hip too. So your patients are really thrilled to meet you and super thrilled to leave you and never come back for those second and third doses. But it is important to remember it's not 1.2 as a single injection. You got to make sure you do 2.4. They do make 2.4 units, and you might be able to order those. I'm not sure if you want to give it all to one side or not. Okay, here's the dilemma that we have at Phoenix Indian Medical Center, and I think that you probably have stories as well. When you have it doesn't have to be IHS. This is the same across any primary care facility, but sometimes you have taken care of your patients for decades. And when they had an ear infection when they were 5, they were given amoxicillin and they have a little rash. So that penicillin allergy gets stapled, stamped, electronically added to their medical record forever. And now they have syphilis. But the question is, do they really have penicillin allergy? Because we know the allergy wanes over time. We know that sometimes nausea, vomiting gets labeled as an allergy when it really isn't. And it's a disservice to patients to have this if they, in their chart, if they really don't have an allergy, because they are given alternative drugs for lots of different things, not only syphilis, when the best treatment are penicillin derivatives from penicillin itself. So we want to endeavor to recognize that anaphylaxis is rare. If you have the ability to do allergy testing for patients you think have penicillin allergy, do it, because this is still the best drug. If it's going to cause a huge delay in getting penicillin, think twice, but desensitization is an important thing to remember for pregnant women. I'm going to say that again, desensitization. What does that mean? That means that for pregnant women, first of all, penicillin is the only recommended drug for syphilis in pregnancy. That means you're not going to give them an alternative. And it also means we don't have an alternative, either in the US or abroad. We only have penicillin. And fortunately, in the United States, not the case in the rest of the world, we can do desensitization. What does that mean? That means you give them very small doses of oral penicillin in a hospital setting. Sometimes it's a tertiary care unit because you're waiting for the possibility of anaphylaxis. And then when they don't have a reaction to that small dose, you give them another slightly bigger dose. Then another 30 minutes to an hour, you give them another slightly bigger dose. And over the course of 3, almost 4 hours, you have increased the doses to dampen their immune response. And then you can give them benzathine penicillin as a full injection at the end of that desensitization regimen. You can Google desensitization of benzathine penicillin. It'll give you the step-by-step instructions. So the thing about that is it's temporary. Just because you desensitize somebody in this month doesn't mean that in 6 months when they get reinfected with syphilis that you can just give them penicillin. No, it's temporary. You've got to start that over again. But please remember, desensitization is required for pregnant women who are allergic, truly allergic to syphilis. But for other patients, we do have doxycycline orally if you think they're going to take it. All right, so we talked about this already. I think we know that syphilis is a problem. It's increasing in the United States, but let's take a look at congenital syphilis. The thing about syphilis in adults, and when there's heterosexual transmission, that directly results in congenital syphilis among infants. So if we take a look for the first time again, this is not the first year, actually. This is the 3rd year where American Indian infants have had the highest rates of congenital syphilis. That reflects a few things which we'll discuss. But take a look at this number. It doesn't seem like a very high number for 2021. By the way, it's going to be higher for 2022. But this reflects a rate. Those 102 cases reflect the highest rate of nearly 400 cases per 100,000 live births in the United States. And when we look closer at this data, and it's preliminary, these 102 cases reflect the 1 in 260 live births of American Indian Alaskan Indians. And that's where the infant was a case of congenital syphilis. We have some prevention success stories. And what that also means is that the number of women who had syphilis in pregnancy is actually much greater. And those prevention stories are valuable, but what the bottom line is we have a lot of syphilis in pregnant women. And the reason we find it is an opportunistic reason. And it's simply because we are screening all pregnant women because that's part of routine prenatal care. But if you're not pregnant, right now you're not getting screened. And it's only in October when the chief medical officer says, now we're screening everybody, that now we're fortunately going to look at preconception opportunities to prevent, treat, and diagnose and treat pregnant women before they get pregnant. So, but remember that this is a huge burden for this infant population, for this adult population with syphilis, for the transmission risk vertically from mother to infant. So we want to really pay attention to this. It's the second leading cause of stillbirth in the world. It's also a leading cause in the United States. Stillbirth is the least common outcome. But neonatal death occurs within 48 to 72 hours when the baby has an overwhelming anemia called hydroxyfatalis. And the circulatory, they cannot support the circulatory needs or the oxygenation needs of their body and they die. There's no way to do a support system for that because it's just too late. So ventilators, antibiotics don't work and they die. A lot of infants are born alive, but they have the clinical manifestations, and that's going to be the next slide, or one of the next slides coming up. I'll show you what these infants look like. And many of them are born alive without documented symptoms. So that doesn't mean they don't have congenital syphilis. It just means that they don't have symptoms, and that we diagnose them based on the fact that the mother's treatment was inadequate, similar to the case that was presented earlier. And that we need to make sure that we get the mothers treated. I'm going to stop here for just 1 second to give you a statement that's important to remember. The diagnosis of congenital syphilis does not rest with presentation of the baby. The diagnosis of congenital syphilis is usually known before the mother delivers, and because it rests on the treatment history in the mother. If the mother's not treated, that's a case. If the mother's treated inadequately, that's a case. If the mother's treated to less than 30 days prior to delivery, that's a case. These are surveillance definitions put out by CDC. They're standard. And those are the reasons that we know and we're ready a lot of times for the baby to be delivered because we've got that IV penicillin ready to go. We know the baby's coming. If the baby, of course, is born with signs and symptoms in an adequately treated mother, well, that supersedes the concern that the mother was treated adequately. If we see these signs and symptoms, then again, that represents congenital syphilis as well, and in addition to the mother's treatment history. The single biggest contributor to congenital syphilis in the United States and congenital syphilis in Montana is the fact that pregnant women are not accessing timely or early prenatal care, and they are not being tested in a timely way that allows us the time period to get all of those doses of penicillin in before the baby's born. And that means that pregnant women are not coming to antenatal care. I think we heard some of the challenges from Dr. Cook-Shanani. Women are concerned that the infant will be taken away because they are using substances. They may not come. When they're concerned because they don't want the pregnancy to be known by partners or family, they don't come until too late. Or other reasons that keep women away from prenatal care, which can be related to transportation, childcare, other socioeconomic factors that keep them away. We need to find those, address those, and increase the trust of the medical system to bring them in. The second leading cause is we got them in, we tested them, we knew that they were positive for syphilis, but we couldn't get that treatment in fast enough. And I will say in an analysis that we're doing in Arizona, one of the contributors to that, one of the predictors of having a baby with congenital syphilis is being diagnosed as late latent. Because you can't get all those injections in due to different reasons, follow-up, loss to follow-up, the interval for giving those second and third doses was exceeded, you've got to start over. These are some of the reasons that we need to consider opportunities, both innovative and traditional, to get patients in for treatment. Okay, so here we go. This is the congenital syphilis rates for the United States. We're dispersing these graphs into some of the clinical criteria so that you can have a little bit of a back and forth. But you can see that American Indian Alaska Native infants have had the highest rates of congenital syphilis since 2019, 2020, 2021. But look at that surge or dramatic increase between 2020 and 2021. We can't blame everything on COVID-19, but this is one of the things where we probably did miss the boat. Again, where women were not presenting for care, they were not accessing healthcare for other reasons related to COVID, and that we have missed some of the diagnoses among women who were not pregnant in 2020, then became pregnant in 2021, and we missed the diagnosis. When an infant is born with congenital syphilis, they can be born without symptoms. But when they do have symptoms, they can be very severe. These are pictures of things that you can see with pictures. But keep in mind that they can have meningitis, they can have optic nerve, otic, cranial nerve abnormalities, they can have heart conditions. Syphilis goes to the large vessels of the heart. These are photos of infants that have obvious symptoms. There are skin manifestations, kind of like in adults with secondary syphilis. Enlarged liver and spleen that contributes to the overwhelming anemia and fatality of infants when the blood cells are sequestered by the liver and spleen. They can also have a thick discharge from their nose, which has all of those bacteria in it. And syphilis organism, Treponema pallidum, goes to the long bones. So you can see that the infant at the far right has decreased opacification of one of their femurs. That's very characteristic of syphilis in the early stages. This is a matrix for your information, but it is complicated how to diagnose syphilis in the infant. But what we want you to remember is that simple statement that congenital syphilis primarily rests on the diagnosis and treatment of the mother, not the clinical presentation of the infant, although that is seen, of course, in untreated women. But we do consider congenital syphilis as a diagnosis based on the treatment of the mother. When a baby has congenital syphilis, they need to be admitted right away, and they're given IV aqueous penicillin for at least 10 days. If the risk is very, very low, and you just want to do the better part of valor to make sure that the patient, the infant doesn't have congenital syphilis, you can give benzathine penicillin as a single injection. This may be a little bit more complicated for us to think about. Syphilis stillbirth is a tragedy for the women and for community. When you have very small communities with syphilis, you see these congenital syphilis births, and the impact of a single stillbirth is very great. What's important to remember is that women also experience miscarriage, and CDC doesn't even recognize that. We only track the stillbirths, and that is a specific designation, a specific definition that requires a 20-week gestation fetus and greater than 500 grams of weight. But there is also miscarriage. We just don't even track that. And so what's important to remember is this is a reportable condition. We don't want to leave this out of surveillance. We definitely don't want to leave this out of the counseling messages for adults and particularly women of childbearing age. Here's a few more resources for you to consider. We're going to go into now some challenges and opportunities, and then I'm going to talk about some of the outbreaks that we've done investigations on. We're going to talk about some success stories and some challenges in other tribal areas. And then we're going to sort of end up with, question answers if you guys are interested in it. Probably might be great. All right, here we go. Stay with me here. So congenital syphilis, I think it's helpful to consider just a brief case and how complicated it is when you have a pregnant woman who needs prenatal care. She may be using substances, so she needs substance abuse counseling. She has sexual partners, so you need a disease intervention specialist to go out and get the sexual partners to bring them in for treatment so she doesn't get reinfected after you treat her. All of this requires coordination. It requires staff presence. It requires continuous communication and collaboration across the different services in order to take complete care of this patient. So that's our biggest challenge, but the biggest challenge to remember that is important to support is disease intervention. That's bringing those sexual partners in for treatment and care. All right, so partner services. This is what we call a word for case investigation, contact tracing. These are the sexual partners in cases. And when there is a deficit in the staff numbers that can help to do this, please reach out. Reach out to the service unit, reach out to the state health department, your clinical director. Find a way to reach out so that we can get this service covered for the patients. And we need a lot of communication over time to make sure that we have this under control and this staffing pattern covered. All right, so so here's some outbreak response and best practices. I'm not going to read through all of those, but I do want you to remember that for congenital syphilis, it's recommended that pregnant women get tested 3 times during pregnancy. Early in prenatal care, again in the 3rd trimester, and again at the time of delivery. And why is that? Congenital syphilis is devastating if you acquire it in pregnancy. And when you acquire it in pregnancy, there's nearly 100% chance that that fetus is going to be infected, and that the devastating outcomes that occur are more common when the mother gets infected in pregnancy, as opposed or in comparison to when she had syphilis before she became pregnant. So it's important to remember that if you have a negative test in the first prenatal visit, that pregnant women are still sexually active and they can acquire syphilis later. And if you miss it at those later stages of pregnancy, you're likely going to have a very bad birth outcome. So again, first prenatal visit, early in pregnancy, 3rd trimester, again, and at delivery. And then, as we mentioned before, sometimes the first prenatal visit is at delivery. And so that's going to be too late for all of us, including the mom and the baby. All right, we also want to endeavor, and I talked about this before, I'm going to mention it again, try to rule in early syphilis. If you can rule in early syphilis, you have one and done. One treatment with benzodiazepine penicillin and you're done. Patient doesn't need to come back. You don't need to try and track them to keep them within those intervals of the 2nd and 3rd doses. If you have to diagnose them with latent or unknown duration syphilis, keep in mind that that increases your risk for congenital syphilis, just because it's hard to get that treatment completed. All right, so let's keep going. We want to make sure that we support the idea locally that it is good to have congenital syphilis rounds, and I was happy to hear this is being put together by the state so that you can share experience, share cases across, and learn from one another. These are the recommendations by the Chief Medical Officer. I'm not going to review those, but these slides will be available to you so you can review and think about the implementation at your facilities. I want to talk briefly about express STI testing. This is one of the Chief Medical Officer's recommendations. It was a holistic, syndemic-based approach, and what that means is that patients should be able to walk in to the front reception and say, I want to be tested without an appointment, without a provider visit, without a physical exam, if they have no symptoms. So if they have no symptoms, we should have walk-in services where on demand, the patient can go to the lab and be tested for STIs. Now, if a patient is a partner to a case, if the patient has symptoms, well, that's different. Those patients need to go see a provider because oftentimes, 100% of the time, we should be offering presumptive treatment. But these express testing services have a lot of value. They can reduce the burden on providers for extra visits, they can expedite a patient's ability to be tested, and they can expedite treatment. So again, Chief Medical Officer recommendation, if you need a protocol, just scan this QR code. We've already written a protocol that you can adapt and adopt at your local facility, and this includes all of the relevant information related to treatment as well. It reduces wait time, it reduces provider visits, it streamlines the process, and it really maximizes limited resources where you're not filling up appointments with patients who are asymptomatic but know they've been exposed. Yeah? All right, let's keep going. Okay, so now we're going to move into some examples of outbreak investigations. Montana is not in this alone. We have outbreaks occurring across the nation, inside tribal communities and outside tribal communities. It's not unique to any one population. We see increases across all race, ethnicity, across all states, and we are all in this together. But what we do have are some best practices, and best practices have been collected and put together from outbreak investigations. And for the sake of this discussion and for this symposium, I'm going to present some of those that have been gleaned from outbreak investigations among tribal areas. So let's start first with one of the outbreaks. Now, the data that I show here, the reason I can show it is because I have the tribe's permission, and as an insurance, these are publicly available. So these are accessible. We don't have to worry that the tribe is not given consent. All right, so this is North Dakota and South Dakota. This is a Standing Rock Reservation. You guys know the geography of this well. It's to the east of you. This is an outbreak that happened in 2013 roughly, where the state health department noticed an unusual increase in cases of syphilis that they reported to the state health department. They reported to the IHS. It was actually the IHS Standing Rock Service Unit that noted these increases. And then they reached out to CDC. CDC said, yes, we'll come and do an FEA. An FEA is where we go out and we take experts in the particular field. We do a review of the surveillance data. We offer recommendations, and sometimes we can attach clinical investigative services to that. So the FEA was something that was requested by the state and the Indian Health Service at that time, but before the FEA started, they implemented an electronic health reminder. This is another recommendation. The electronic health reminder went into the RPMS system for IHS service units, and other R638 facilities and private practice facilities also adopted this, so that everybody who came through that was going to get a blood drawn also had the blood tested for syphilis. The AHR reminder was implemented, you can see, in January of 2014. The CDC team, that included CDC staff, IHS staff, county staff, state staff from 2 states, and local private practice and private hospitals, all led an ongoing on-site response that resulted in a steep increase in cases. Now, is that a failure? Actually, no, that's a huge success. When you implement the response to an outbreak, that's exactly what you want to see. Do you implement your interventions? You want to see case finding. So the case finding went up after the on-site response and the finish of the CDC on-site presence. The state, the Indian Health Service, and the counties continued to sustain the intervention and outbreak response activities. And even with that full-scale support, it took 2 years to come down. So what I want to tell you now is we're in this for the long haul. We're in this for the long haul at the United States national level. You're in this for the long haul in Montana. But what I need for you to understand is that once you go full court press, you need to stick with it. It's exhausting. It can be confusing. Syphilis can be a difficult disease to diagnose, to understand, and to address, because it takes a lot of different services to fully make sure that the patient receives the best services. All right, let's keep going. Here's some of the best practices from Standing Rock. The increased prenatal screening first, third trimesters and at delivery. This was back 10 years ago, so this was already a good practice at that point. Community awareness, symptom seeking, educating providers was a critical part. Implementing electronic health record reminders and screening high morbidity areas, and that included corrections, schools, universities, and high schools. It also included community outreach events or community-based events. And they prioritized training, and they prioritized partner notification, the best case finding method. Okay, let's move on to Central Arizona. This is the White Mountain Apache tribe, which is in northeastern Arizona, not too far from Phoenix, actually. They had an outbreak of syphilis in 2016. They notified CDC, the state, the county, and they implemented an on-site response. They had great case finding ability. You can see congenital syphilis are those key little black boxes at the top. They were successful during their outbreak response. I'm just going to point to this and re-emphasize this one more time. You see how early syphilis, they were able to rule in early syphilis here as the light blue bar on the top of the stacked bar. One of the reasons they were able to do this is they were able to pinpoint from the beginning of the outbreak some of the index cases as contacts. Rule back in the sexual exposure of new cases to the contacts diagnosed in August. That made those early latent cases not late latent. Right, so this meant they only need 1 injection of benzathine penicillin, which also allows for a successful response when you can rule in early syphilis. And then they had full court press, but again, just walk down this point of this irony, they ran out of penicillin because this was the international shortage. So that was a stutter, that was a sort of a halt or a hiatus, unfortunately, where they ran out. And then they had cases persist. And even you can see that they had an increase here because they weren't able to get to all the cases. So these are some of the stumbling blocks, but also success stories that I think is important for us to use and understand when we start to address this here in Montana. And let's hope to goodness that we don't get to this event, to the to the lack of benzene penicillin, but we might. It's a real reality. There is an alternative, it's doxycycline, but it's very difficult to be compliant to take all those doses. So we want to use our penicillin while we can. Their best method of case finding was contact tracing, finding the sexual partners. That's where for any infectious disease, that's where you're going to find the cases because it's communicable. You don't need to screen the whole population to know that if I was in contact with this person's more likely to be infected. I think you guys get that. We've all been part of this now. Okay, Southern Arizona, this is the Southern Arizona outbreak. This is probably the best or the last example that really is related to what we're going to be looking at here. This is a tribe, Tohono tribe, one of the Pima Indian tribes in Southern Arizona on the border of Mexico. And they started to see increases in 2006. They called the State Health Department, Arizona Department of Health Services. They notified IHS, which was where some of these cases were being diagnosed. And then the tribe, by tribal resolution, declared an outbreak and requested CDC assistance. So that's usually the method when the tribe requests assistance, they do a resolution and they go directly to CDC. So there was an on-site multi-agency response, IHS, state, county, tribal health departments, and also local community-based organizations. Everybody was on site, increased case finding. Take a look at the congenital syphilis cases were quite devastating for this very, very small community. And with their sustained efforts at community-based screening, aggressive partner services, door-to-door screening in some situations, they brought the outbreak to a close in 2009. So that's 2 years, 2.5 years nearly. And here's some of their best practices. They're no different than what we already talked about. So these are the ways that we know we can find cases, bring them in for treatment, and stop transmission. That's the most important thing to remember. All right, Alaska experiencing ongoing issues. A lot of their cases are co-infected with both HIV and STIs, and they now, at least in 2020, haven't seen their 2021 data. They are experiencing a large number of congenital syphilis cases, whereas the state never had it. So again, this is pervasive, and we are seeing this across the United States. I want to stop here by saying that even though we're going to give you these recommendations, these best practices gleaned from American Indian communities, adopted by the Indian Health Service, recommended by the Chief Medical Officer, these are still local and facility-based decisions. And if you decide to implement these, they are still going to require local adaptations for true success. And that success requires champions. It requires mobility. It requires, working at the top of your license, as we call it in IHS in Phoenix. It means we need all hands on deck. And so these, we want to make sure that we consider the opportunities for incentives for patients to come in so that they can feel that they're part of this and that we have engaged them in a way that helps them. And we also want to make sure that we consider the opportunities to take the services to them. And as an example, taking benzene penicillin to them. This is a QR code for these best practices. And again, these would require some adaptation locally to best fit the situations and contexts that you're in. And like I say, we'll give you these slides, but if there's any questions, I can potentially take those now, or we will turn it back over to see. Thank you so much. It's a pleasure to be here.
So it's been a very, very dense morning. Dr. Taylor, I want to stay up here actually. Because we only have one day with you. And so we really wanted to get you as much information as possible on the clinical side. And then, as I said, in the afternoon, there'll be working sessions and a little more interactive. We have one more presentation this morning. But I want to break it up a little bit with, start with some question and answer now, since you've just gotten so much information. The other thing I want to remind everyone, if you did not register via email or through the form, we'd like you to make sure to sign in out front, because if you want to get these materials and have all of this information, we need to make sure we have your email. So I think you may have missed some of your registration, so just please remember to sign in. But let's start with some questions. And we'll have a little break, and then we'll come back for Jessica's presentation and then lunch. But we definitely filled your heads this morning with a lot of information. So would love to have some Q&A. And again, Dr. Taylor will be here all day. But yeah.
Okay, are you calling on me?
Yes.
Okay, so I don't know if I heard you right. Did you say that syphilis is most transmissible vertically during the secondary stage? Okay.
So this is a good question. When is syphilis most transmissible? It's most transmissible in the secondary stage, and then the next most transmissible stage is the primary stage. When you're in the primary stage and you see that chancre, sometimes the bacteria are stuck in that area. It's not as a widespread dissemination as when you were in the secondary stage. Okay, yeah, good question. Anybody else? Go ahead.
Yeah, one thing we struggle with is when we test and we get a positive test, we know they've had syphilis previously. Their treatment, they said they've received treatment, but it's a large transient population, a lot of corrections. We're not really sure where that was. Their titers come back at like that 1 to 1, 1 to 2. And we're trying to figure out, is that a successful primary treatment or is this potentially a reinfection? Is there any sort of recommendation as far as your threshold when you would go ahead and treat again when you don't necessarily know if they were successfully treated the first time? And I've looked at the recommendations and it's just, you know,
Yeah, you're not going to find anything. But I will say this is a good case, so I'm just going to repeat it quickly because it has a couple of valuable teaching points. There is a seroscar, or what we call a serofast state. When the patient has had syphilis in the past, they've been adequately treated, you're always going to be positive for the treponema test. The name of the treponema test, you can see it as EIA, TPPA, TPHHS. Those tests are always going to be positive. And then the RPR is really what we rely on to give us the understanding of whether the patient has acute infection or whether their titer has come down successfully after treatment, and also sometimes whether or not they've been reinfected. For the most part, it takes about a year for a patient's titer to come down after treatment. If you're HIV infected, it takes about 2 years sometimes because you have a lot of inflammation in HIV. When that titer comes down, it can go to, let's say, 1 to 8, 1 to 4, 1 to 2, 1 to 1. We're looking for a 4-fold titer decline to consider that as successful treatment. So a 4-fold titer decline is a 2 titer decline, so 1 to 16 to 1 to 4. That's just divided whatever you started with by 4, and that is considered a successful treatment. When we see titers in patients who have been previously treated of 1 to 1 and 1 to 2, we don't want to do anything for that. When we start to see titers of 1 to 4, 1 to 8, then it's probably good you talk to your state health department to see what prior positive results in RPR titers you've gotten. In truth, and these are cases from Arizona, I've seen patients that just stick at 1 to 32 for years. Some of them have HIV. I've seen patients who come in with a valley fever. We have a fungus in our soil. It's called coccidiomycosis. And cross-react. Seen them stick there at 1 to 32 with cocci. We've seen false positive RPRs that come from pregnancy, from lupus, from rheumatoid arthritis, from Ehlers-Danlos, from a lot of other connective tissue disorders. There's been false positive RPRs from COVID-19 infection, COVID-19 vaccination, flu vaccinations. So that RPR is not a syphilis test. I don't want to say that. I don't want you to remember that. But I do want you to recognize that there are reasons for it to be false positive. It's actually an antibody on the inside of your blood vessels. It just so happens to produce itself when there is a syphilis infection or when you're injecting drugs into your veins. So IV drug use is another false positive situation. And the syphilis organism goes to the blood vessels and it stimulates this antibody response. But it is still our most valuable indicator of new infection among patients who have old infection, repeat infection among patients who have been treated but re-exposed, and it's our most valuable indicator of success in treatment after we give penicillin. So I hope that's answered your question. I've added a lot of other things to it, but again, it adds a little bit of complexity to syphilis diagnosis and that RPR interpretation. But the bottom line is watching it come down and hope that it doesn't go up again to designate reinfection. But 1 to 1, 1 to 2, just let that go. All right.
I'm a public health nurse in Great Falls, and we use a lot of the times is getting incomplete information from the providers that provide us, like the fact that they sent us. Just wondering if you could offer us any insight onto what is the provider's accountability for accurate information?
Yeah, the providers don't have a lot of oversight from outside as to what they're required to report. But if the clinical case reporting form that is put forth by the state, they are obligated to report. But I think that there's not necessarily any policing, and maybe, I don't know if someone else, maybe Christine can answer this question. It's a little bit different in every state.
I don't have the exact reference, but it is in code. So the Montana Code Annotated lists out exactly what they need to report. And so it is a statute in the state of Montana, and it provides that information, and we can provide that link to the slides as well. Sorry, I don't have the exact reference.
And I can say that in different states, it's the jurisdiction of the state health department to request medical records. And so the health departments do have access to the medical records, and you can request that from the diagnostic facility. That's helpful. Did everybody hear the question? Okay.
I have a comment on that.
Okay.
The laboratories here in Billings, I'm Jean Brayton. I am a nurse practitioner and I do Allison care for a children's clinic here in town. It seems like the laboratories that we do our testing at automatically report to the health department. And and so I think providers get a little bit lazy about doing it. I came from a public health clinic when I joined a private practice, so I was in the habit of doing it. But I know a lot of the pediatricians I work with don't, and just rely on it going automatically to the health department so that they do it.
They may not know, actually. It might be worthwhile to retrain them.
Yes. So I encourage it, and a lot of times I'll do it for them. And I'm doing most of the STD testing for Allison here. Also, one other thing, when we talk about giving the penicillin injections, I have a young client who had rheumatic fever, and I have to give her an injection once a month. She started this at the age of 13, and I have to continue it until she's 19, I believe. She comes in every month, so I've had to be really kind of creative in how I deal with her. And when I have the injection, I use a little lidocaine, and I pull back the syringe and put about 2 millimeters of cc's of or milliliters of the lidocaine in there, and it seems to help her dramatically. And sometimes if she's really freaked out about it, I will kind of inject a little bit of lidocaine where I'm going to put the penicillin, and I do that beforehand. Let it kind of sit for about 2 minutes, and then I go in the same tract and do the penicillin. And she seems to have tolerated this. It's been going on now for like 3 years, so that's an idea.
Yeah, that's great. Thank you for sharing that. Really got it. Couple of questions over here, I think. We saw a hand over here. Okay. Here,
I don't need a mic.
Okay.
I was just wondering, so we recently had a case in our area, and I really kind of had my eyes opened by this particular case. And then looking at all the data that you presented, I got to thinking, in the Native American populations, is it possible, and has it been studied, because there hasn't been the exposure in the Native American population as there has been in Euro-American, because it's been with us for perpetuity. So is it possible that it's new to the Native American, DNA structure and stuff, much like the other European diseases that we brought over with us? And the other thing that caused me to think about that population and how it's segmented out and alarming is this person, I'm thinking sexual transmission, which is a little narrow-minded. And this person told me, I haven't had other partners, but I believe that I've transmitted it to my partner through communal drug use. And so I said, okay, so is it IV drug use? No, meth, pipe use. And I just wonder if there's like maybe a correlation now too with Native American populations. If that is some sort of tie, has that been studied? And I mean, doesn't matter, but in the big scheme of things, but why such a disparity?
Yeah, so there's a couple of reasons. It hasn't been studied. We don't suspect that there's predilection for syphilis among American Indian Alaska Native populations, but one of the reasons that we suspect that the amplification of syphilis has occurred in American Indian Alaska Natives is due to small sexual networks, and sexual networks that remain within the racial ethnic group. And then there's also concerns, there are social events that might facilitate sexual transmission that occur from across the west part of the United States that include, all the community events that I mentioned that really are big draws for tribes across the United States. Some of the bigger rodeos here in the Dakotas and then the rodeos that we have in the spring bring folks up and down. There's also connections potentially to remote work in some of the Dakota areas where there might be transmission. But we don't think there's necessarily a predilection by race, but we do think these smaller sexual networks where the disease might be taken back home, one after travel or brought forward into a travel situation might have something to do with the transfer across tribal areas and over this last period. Regarding your second question, which, what was the second part?
Well, it opened my eyes that, that could be, of course, a mode of transmission is the
non-sexual.
drug use.
Yeah, non-sexual. Yeah.
Okay.
Okay, yeah, theoretically, and actually, you can have bloodborne transmission of syphilis because it's a circulating bacteria in the bloodstream. It doesn't really happen. We can't really identify it most of the time. It's really impossible to say. But it's absolutely orally transmitted. Absolutely. High efficiency, the oral mucosa exchange is absolutely a very efficient method of transfer. I can't say that we've ever identified sharing of drug paraphernalia as a transmission route, but we would love to. So if there's a way to document that. The problem with syphilis and the bacteria is it's very hard to culture. It doesn't persist very long. And we have to use rabbits to actually culture the bacteria. So these are great questions. Thank you. Go ahead.
So I'm a public health nurse at the county level, and I actually, maternal and child health is my area, so I'm coming from a little different point of view. Here's my question that I've not been able to find any resources on. For these children, for these babes that are born to mothers who either were treated successfully or weren't, either way, but for those children, is there any research out there or any information? Are there any long-term implications? So like we had a case where we had a mom who was successfully treated, I believe did all 3 injections exactly a week apart. How our OB office got her to do that, I don't know. But other than that babe being hospitalized for jaundice shortly after delivery, after discharge and then back in, what do I tell that mom to watch for? Anything?
Yeah, so this is one of the ironies of syphilis and congenital syphilis. First, I want to say another statement to remember is that congenital syphilis is not an STD. Congenital syphilis is not sexually transmitted, it is vertically transmitted. So as the STD, as someone who's experienced in STDs like HIV, STD, syphilis, etc., we are trying to manage congenital syphilis, and it is not an STI. So this is where we really need the input of the maternal child health teams, and this is one of the ironies and gaps in the knowledge of congenital syphilis is there's never been a longitudinal study on the outcomes of infants and young children born to women with syphilis. And I say that with quite some irony. I feel it's part of the tragedy of syphilis and congenital syphilis that we've never had the funding support either at the university, CDC, or other research levels at the NIH actually follow infants to look at the outcomes. Now, in the 50s, they did. These were infants, children that were born to untreated women. Of course, we have those documented through photographs of the horrible manifestations of late
congenital syphilis, where you actually see the collapse of the nose, you see the tibias of these infants bow because of the weakness in the bones. You see them die of cardiovascular disease at a younger age. But here in the recent last 3 decades, we have nothing to say among treated or untreated infants what the manifestations are. Because first of all, we cannot allow that type of research. We must treat the infant if we suspect congenital syphilis. But among treated infants, we don't have information on what those long-term manifestations would be. And it's a great question. You're actually the first one to ever ask me that. And we are looking at the possibility of doing that in Brazil because of the tragedy of the loss of NADC penicillin a few years ago. There were a lot of pregnant women and infants that were treated with the incorrect antibiotics simply because there was no penicillin. So it's not the ideal situation, but in a natural setting, a natural history setting, we do have the opportunity now to look at that. But it requires funding, and we haven't given that yet. Okay.
Stephanie, did you have?
Oh, yeah, go ahead. Hi, Stephanie, yeah.
Sorry. I'm gonna bring it up.
Good morning. My question is, and this is, I mean, I'm just gonna guess that it might not be a question necessarily for you, but something to consider with syphilis and diagnosis, especially on the reservation or in our tribal communities, is when it occurs, and I was just thinking about my time with OCAT, is if we got a kid that came in that said they wanted to go get tested for syphilis, that would be a red flag for me. And I would say, are we supposed to report this? So is that, you know, a barrier to seeking out screening or treatment at the younger ages? And that's my question. Of course, tribal governments are different. As far as law and order codes go, I have no idea, but I know there's some tribal folks in here that maybe might know from their experience. So that was kind of my question.
Anyone wants to think about that, raise your hand to address it, but why don't we have Maggie from DPHHS talk about my consent for my.
For sure.
And this is start, and then if there's any tribal representatives that have more information.
Yeah, and this conversation actually came up yesterday because we were talking about Montana code, where a minor, there is an exception for treatment of evaluation and treatment of minors for sexually transmitted infections. If they're pregnant, if there's a concern about substance use, there's an exception in the code in terms of treatment. And minor in Montana is defined as someone less than 18 years of age. But the big caveat being that that's not going to be applicable in situations where tribal code is different. And so we were just curious on kind of what that looks like, or if people had, you know, experience, or somebody's raising their hand, so I'm just going to bring the mic back.
Hi, everyone. I actually work with Cora. I do a lot of clinical compliance trainings for behavioral health. And so it gets really complicated. So tribal jurisdiction would apply if you're a member of that tribe and the child's a member of that tribe, and then you refer to that jurisdiction. But at the same time, your professional licensing would require you to follow Montana code. And so what I can do is I can share across the Montana codes that apply. And so I believe it's at provider discretion, age 14 and up, for the treatment of STDs and pregnancy. And then for all other mandatory reporters, age 16 and up, for being able to consent for treatment. But I can share those codes with Cora at the break.
Thanks, Megan.
And so Maggie, again, to confirm, under 18, you can be tested and treated without consent in Montana. The statutory, yeah. Okay.
But this is different. This
Right.
is talking about license.
Right.
Well, there's Montana code annotated, and then it's also reinforced under mandatory reporting laws. It gets complicated, but I'll share it across. So 14 primary medicine at that provider's discretion, age 16 and up consent. Consent. Although the parent owns the Medicaid policy for across that way.
Yeah, but this is a question that's come up quite a bit. So we're going to make sure that follow-up materials include this, because we are, and especially if it's transmittable through, right, if it's sexually transmitted, but, you know, orally, that, you know, we're starting to see more and more in young populations. Do you want to say something?
just to kind of make, oh, yes, I'm sorry, I'm Stephanie Iron Shooter, I'm the Office of American Indian Health Director for the department. And so nothing is absolute, I'm gonna put it that way. Nothing is absolute, especially with our tribes and our tribal governments. So even though it's state statute and reporting, reporting guidelines does not necessarily mean that for the law and order codes on the reservations. And so just to keep that in mind, if you work with tribal people, please keep that in mind, that to try to figure that part out on if you would report, when you would report, if kids can't report because they're scared of getting their folks turned in, or you know what I'm saying? So there's a lot of nuances to consider, and I just want to keep you all open to that.
Yeah, and if we get updates on that per tribe, we'll also share. Maybe that's something we can try to collect. I know that we also have a lot of, do you have something else to add?
I just have one, no, not
Okay.
totally.
So I know we have a lot of clinical providers in here, but I also know we have a lot of community partners. So are there any questions from our community partners who are not working necessarily in the clinical arena?
Yeah, I've got a lot of voice.
Okay.
This is B-Rad from Missoula, and part of my job is doing education in high schools, take a harm reduction approach to STIs. Syphilis is an STI that we cover. So like one creative thought is, well, the condom only covers 1% of the human anatomy, which given all the possible skin-to-skin contact is pretty small. So I wouldn't rely on that for syphilis. I advise maybe like a skin check, it could be traumatic or not, depending on the personality, but like look before you touch. But what other creative ideas for prevention do you have, or anyone in this room have?
So prevention, and probably also helping to educate and identify, seeing a sore, seeing a rash, and just, helping build awareness about, I think one of the things that's most alarming is the fact that you can have a sore and a rash and then it goes away, right? And so it's like, oh, you just thought you had a canker sore, or you thought you had a reaction to something on your hands, or, and so I think that's one of the things that really is the most problematic with syphilis, is that it will appear and then disappear. So the more our community partners can also help if they see something, or just to help educate the communities you serve with, materials that we can send and share, because I think that it becomes hidden really quickly, which is one of the scary things about it.
And screening. I think that's the only way to really understand if someone has STIs, because 80% of them are asymptomatic. What you see here is the minority of people who actually demonstrate symptoms or acknowledge the symptoms, but most people who have STIs never know it. So you have to be screened if you're at risk. That's the bottom line. And that's the innovation, is we need to provide that screening to our adolescent population. So right now, I don't know that they necessarily feel comfortable seeking it. Yeah, that's a great question. Thank you.
Here and then here. Mine is not necessarily a question, but I know for kids, it's really important to repeat.
Yes.
Give them the information over and over again. Eventually it'll click and they'll start asking questions. But 13, they don't know what to ask.
That's right.
19 sometimes, they don't know what to ask. They're kids. Even some kids in their 20s don't know what to ask. You're kind of moving through your life, and you're exposed to things that, okay, I'm not sure what to do with this. 10, 15, 20 years later, oh, I wish I knew that. So, but with kids, it's repeat. Give them the information over and over and over again. They will get it. They're smart. They'll know where, give them a safe haven as well.
I wish I could have recorded what you just said.
Yeah.
It's inspiring in a way, and I think we all sometimes feel that our messaging falls short, but I think it's not the messaging itself, but the fact that we have to repeat it. And even for adults, you'll be surprised at how many adults really don't know very much about STIs. And you can imagine that if they had had that repeated message from the time of adolescence, where they knowledge builds. You've got to start it, and then it builds upon itself, and then that's how they create their healthy behaviors or not. And so that's really where we all need to step in, both as educators, as parents, as community members, as healthcare providers, as community-based organizations. We all need to step in and help with that messaging. So thank you. I don't even have a comment to say beyond that, so I just appreciate you saying that. Thank you. Okay, go ahead.
Hi, my name is Mallory. I'm a researcher and sexuality educator, and I work for Tech Tribes, and I really want to respond to Brad and to everybody who's engaged in the community and prevention of sexual.
Any questions that? This is something that everybody's already employed. Louder.
You just put it right up to your mouth.
There we go. So my name is Jessica Riestra. I use she, her pronouns, and I'm a psychiatric mental health practitioner. Thanks to Cora for getting through all of that jumble of words. But just a reminder, at the Northwest Portland Area Indian Health Board, we serve the 43 tribes of Washington, Oregon, and Idaho. But being able to work at the health board in national scope, we also work closely with Indian Health Services, HIV, HCV, and STI programs to assist and support all IHS and tribal clinics with current needs. And currently that need continues to include addressing this endemic and syphilis in specific. And I really do appreciate being in this room with all of you incredible humans who have come together with the shared goal of improving the health of our loved ones, neighbors, and communities by ensuring that they're getting the best possible treatment options and that we're finding ways to provide those for them. So to start off today, I want to share a case. This case was recently presented in our congenital syphilis grand rounds last month. And this clinical case creates some questions for me. So I'll go through the clinical part of it first. So we have Tiffany, a 17-year-old, presented to the emergency department in late October 2022, reporting symptoms of a UTI. When tested, the UTI came back positive and also positive for pregnancy. And this facility was very fortunate within the IHS tribal and urban health system that it had an ultrasound and also an ultrasound technician that was available at the time of the visit. So they were able to perform the ultrasound and it showed that she was 14 weeks pregnant. During this visit, she was treated for the UTI. She had prenatal labs drawn and sent out, and she was referred to the prenatal clinic. So this visit was October. The results of these prenatal labs included an RPR that came back 1 to 128. She had a positive TPA and positive chlamydia test. All of her other labs were negative or unremarkable. So multiple phone calls and a public health nurse visit later, Tiffany presented back to the clinic in early December 2022. So 2 months have gone by. At this time, she presents with a rash. She reports she's no longer with her partner that she was with in October, but declines to name who that person was. So at this early December visit, she was treated with penicillin for secondary syphilis and azithromycin for chlamydia. She had prenatal care and ultrasound arranged. The day of treatment, she had her blood drawn again, and her titer returned at 1 to 64. So in late January, after several missed visits for prenatal care, she returns to the clinic for an ultrasound and a second prenatal visit. Her labs were drawn during that visit again, and her RPR was 1 to 128, and she was positive for chlamydia. So in early March, after extensive outreach efforts and missed visits, the public health nurse at the site found her. She was at a house that was associated with methamphetamine use. She had reunited with her partner Marcus, who was originally hadn't been treated because they had split up and she had wanted to name him at that time. That same day, the amazing public health nurse who was at the site was able to treat both Tiffany and Marcus with field treatment and was able to screen and draw labs for all of their STIs. Follow-up care was arranged for Tiffany, and follow-up care was also arranged for Marcus for the staging of syphilis. Despite really extensive outreach efforts, Tiffany is not seen again until early April in labor and delivery. She was 36 weeks and 5 days. She had elevated blood pressure and apparent intoxication. She was screened and was positive for methamphetamine. She delivered a 5-pound 14-ounce baby with APGAR of 7 and 6. So Tiffany's baby, the maternal RPR at delivery was 1 to 16. baby RPR 1 to 32, no obvious findings consistent with congenital syphilis. The baby had some respiratory issues and was transferred to an outside NICU, received a full evaluation, including CSF analysis and treatment with penicillin for 10 days for possible congenital syphilis. And subsequently after that was lost to follow-up with some family members reporting that they had left the area for a sober living home in another state. So this de-identified case was initially presented for a variety of reasons, and they include the complexity of the case, reasons of reinfection, for the overlap with substance use, specifically methamphetamine use or polysubstance use, which is really so common with syphilis diagnosis now, specifically women, but also with a lot of the congenital syphilis cases. But as the OBGYN presented this case to us, there were a lot of questions that I had about Tiffany, because this case was quite clinical and was definitely presented from the point of the clinician and the healthcare system. But what does this case study look like from Tiffany's point of view? From the very beginning to the very end. So for that first ER visit to have happened, how hard is it for her to get from her living situation to the ER on that day? For follow-up, when she did make her appointments, what did it take for her to get to those appointments? On multiple different levels. So transportation, social support, was there somebody controlling what she was doing or weighing in on her activities? How are drugs coming into play with these decisions and her accessing the system? Also, if she is pregnant and she continues to utilize substances, is she scared that her baby's going to get taken away from her? Because just because she's using doesn't mean that she wants her baby taken away from her. There are all these different factors that come into play from the point of view of the person who has syphilis. And I don't think we're fully addressing them, at least not exhaustively. And if we continue not to do this wraparound care to fully address each of these different levels, we're not going to get ahead of syphilis treatment. It's going to continue to get away from us. And because the healthcare system is just not set up for people who use drugs. We need to really rethink about access to care for people who utilize drugs, because they are one of the most disenfranchised populations. So there are multiple factors that are contributing to the rise in syphilis and congenital syphilis rates. Several of them have been discussed already, but as somebody mentioned, repeat. I know I need that, so I'm going to do it as well. Lack of prenatal care. Adequate prenatal care is essential for preventing congenital syphilis, as it allows for early detection and treatment of the infection. However, some women may not have access to prenatal care due to barriers such as cost, lack of transportation, or lack of health insurance. Lack of screening. Pregnant women who are not screened for syphilis may be unaware that they are infected, which can lead to transmission to the fetus. Lack of treatment. Even when syphilis is detected during pregnancy, some women may not receive adequate treatment due to a variety of reasons, again, such as lack of access to the healthcare system or medication, reluctance to seek healthcare due to stigma or fear of discrimination, and this one is huge. Increase in syphilis rates among women of childbearing age can lead to a corresponding increase in congenital syphilis rates, which we're seeing. Other factors, poverty and social factors, such as substance use, houselessness, lack of education, can contribute to an increased risk of syphilis and congenital syphilis. So it's really exciting to see everyone here working on providing education, all of the pamphlets and flyers and getting more information out is a huge part of continuing to spread education. And for those working with kids, I'm just so excited you're here as well. To address the rise in congenital syphilis rates, it's really important to implement all of the strategies to improve access to prenatal care and increase screening and treatment for syphilis among pregnant women. And this can include targeted education and outreach efforts, improved access to healthcare services, and addressing the social and economic factors that contribute to the spread of disease. So last year, the Indian Health Service and key partners created a syphilis crosswalk. It took several previous documents and plans that had been in place and brought them together to provide a template or a checklist that facilities can use in order to best respond to the syphilis outbreak as they are experiencing it. And these include improving and enhancing syphilis surveillance, outbreak response, improve and quality assure clinical and partner services, improve and quality assure laboratory services. Training and staff development, clinical trainings, non-clinical trainings, all on evidence-based action planning, monitoring, and evaluation are available. And there will be, these slides will be made available, so there's a link here as well. If you wanted to look at the chat, to look at the link, you'll be able to review these slides and give feedback on that or fill that out for your facility. There we are. Importantly, we have to have specific interventions for people who are using substances, specific interventions for people who are pregnant, specific interventions for persons who are incarcerated. And those will all also be specific to your unique community and the needs in your community. If we don't collaborate between the healthcare providers, and syphilis will continue to grow. Okay, so we'll go back here. So if you do want to have a look at this document, it is included and will be sent out, and I'd be really happy to, this afternoon or later, discuss and brainstorm specific needs of your facilities or communities and talk about ways that we can continue to support as everyone's addressing each other. A couple of other things we know the importance of creating plans of safe care for people who are pregnant and parenting and their families. Our plans of safe care are divergent from the traditional plans of safe care that are generally very child or protective service system reporting focused. Our plans of safe care for American Indian and Alaska Native pregnant and parenting people experiencing substance use disorders are really focused on creating an environment that wraps around the pregnant person and their family in a system that supports the pregnant person and their family that is, again, specifically designed for that pregnant person. So for someone who is utilizing substances, it ensures doing everything possible to treat them and to keep their family together, and also when appropriate, offer treatment for that substance use disorder if that's something you're already interested in. The guide also offers healthcare providers recommendations for 3 potential points of intervention: prenatally, during birth, and postnatally. And these points of intervention have been demonstrated to improve outcomes for this population and their infants. The guide also contains practical advice for developing and strengthening cross-system networks of community support, which we all know are essential for effectively addressing the expansive ways substance use disorders can impact the lives of American Indian and Alaska Native persons who are pregnant and parenting, their infants, their partners, their families, and communities. So it's this same plans of care that we've developed that is really about a comprehensive and integrated model of care to fill in the cracks of our current system for pregnant people experiencing substance disorders. We know that disconnected services create these cracks in the community care delivery system, and they can fall through when they're on their walk on their journey to recovery. And recovery works best when supported by comprehensive and tightly integrated support services. Research and practice demonstrate that individuals experiencing substance use disorders benefit from connection to a strong base of integrated community supports, such as those that provide food, clothing, transportation to and from medical services, job and life skill development, and childcare. And even though we know this is true, most substance use treatment programs accessible to American Indian, Alaska Native pregnant and parenting people lack an adequate level of comprehensiveness and integration. And this results in what we're seeing medical, social, cultural, spiritual, and other support services being physically separated, or difficulties coordinating care, infrequent communications between cross-department or interagency care providers. So using an integrated model of care where pregnant and parenting people experiencing substance disorders are provided substance use counseling along with mental and behavioral health services, primary medical care, social work case management, and other needed services under one roof, or when that's not feasible, collaboratively, offers pregnant and parenting people experiencing substance disorders and their infants, partners, and family like a one-stop shop for recovery to serve the needs of infants impacted by STDs. This model would also include the integration of pediatric and family medicine, as well as developmental care services. To serve the needs of partners and families impacted by STDs, this model should include a family-centered approach, because research demonstrates that treatment recovery and family well-being outcomes improve when the complex needs of each family member is met through clinical treatment and related support services. A couple of innovative ideas that are in the plans of care Again, transportation, on-site childcare, advocating for transitional and recovery housing, establishing a tribal healing to wellness court, establishing inpatient facilities for pregnant and parenting persons that allow children. So with all of that, what we're trying to build, what do we know? We know that connection fights addiction. We know that the trauma, the grief, the loss, and the stress are best addressed with healing, joy, bonding, and peace. And this is done relationally and not in isolation, with community care and not responsibility on self-care. You figure it out. It's about the community wrapping around this person, their infant, and their family. So I wouldn't be up here if I didn't get a chance to talk about harm reduction. And because there are such close ties we're seeing to substance use disorders and the rise in syphilis, it's important that we all think about ways that we can increase harm reduction in the services that we provide. And while this can be somewhat of an emotional topic for some, harm reduction is something we provide throughout all of healthcare for all types of chronic diseases. And substance use disorder is just one of the many chronic diseases that we can provide harm reduction for. It's a way to re-engage with patients who are not otherwise accessing the healthcare system due to stigma, to ensure that screening, point of care screening is done, to offer protection from transmissible diseases. And again, we know that stigma causes shame. Shame causes silence. And as we can see in all of the data that's been presented, that silence is hurting all of us. The numbers are going up. People who use drugs and alcohol are people first. Their friends, neighbors, brothers, sisters, and our relatives. So they deserve the same access to care as everybody else that we treat. The side note, harm reduction is also incredibly cost effective. This is an old slide, so savings are even more increased, but yeah.
Can you just, for anyone again who's not clinical, can you just define harm reduction?
Yeah, absolutely. So I think harm reduction, there's a capital H, capital R is like this movement of harm reduction, thinking about providing care for those who utilize substances. I am speaking of it here with that mindset, but also thinking of harms reduction as the ways that we all minimize harms every day. So wearing a mask reduces your harm, putting on sunscreen reduces your harm, wearing your seatbelt